the guest. I welcome you to the POSI's new initiative that's Meet the Author. And with that, we are looking not only for the scientific part of the article, but we want something beyond that, like the struggle, the obstacles you faced while writing the article or while conducting the research. So I request both Jim as well as Harold to share something on that, because that will help us to persist in the difficulty which we face in our research journey. So naturally, we are interested in the scientific material, but we also look forward to this insight also. So with that, I request our Secretary of Pediatric Orthopedic Society of India, Dr. Sandeep Patwardhan, to give introduction about our guest and the faculty of today's program. Over to you, Sandeep. Thank you.
Thank you. Thank you, Dhiren Bhai. So it's my proud privilege to welcome two giants to read their papers on two very important aspects. One is how to manage recurrence after Ponseti casting, going back to the cast, which is going to be delivered by Dr. James Wright, and redirectional hip osteotomies by Dr. Harold Bose, who's no stranger to Indians now, and he's got remarkable work in arthrogryposis. To introduce these stalwarts, Dr. James Wright, I was just reading his CV, and his work goes beyond orthopedics, beyond pediatric orthopedics, and he's now into a lot of administration and really making a difference to the way practice is conducted in Canada. He was at Sick Kids and he was responsible for the operation of 6 surgical divisions, which is cardiovascular, general neurosurgery, orthopedic, plastic, as well as urology, and 5 departments, that is anesthesia, critical care, dentistry, ophthal, and ENT. He's not only a great surgeon and a researcher, but he's a leader in perioperative services staff, including a high level of engagement in complex clinical care, basic and clinical research, including undergraduate and postgraduate education, as well as he's responsible for a lot of administrative responsibilities. He's won a lot of awards, the most notable being the Robert Salter Award for Excellence in Orthopedic Education. He's also been awarded the Orthohine Award by POSNA, and his highest honor has been the Order of Canada, which is Canada's highest civilian order. So we really have a giant amongst us. And let me welcome Dr. James Wright on behalf of POSI to deliver the first paper on casting techniques after recurrence after Ponseti cast. The second speaker for the day is Dr. Harold Bose. As I said, he's done outstanding work in arthrogrypotic children, and he's at the Shriners Hospital at Philadelphia. He's been with us on many webinars earlier, and he does human work in Americas, Asia, as well as Africa. And 90% of his work revolves around managing Prader-Willi syndrome and arthrogrypotic children. So he's really a super specialist dedicated to a specific area. And we would love to hear from him about hip osteotomies for hip deformities and arthrogryposis. So let me welcome these two gentlemen and hand over the proceedings to Alaric and Rujuta.
Thanks, Sandeep. So if I can ask Dr. Jim, so the stage is yours. We'd love you to share your thoughts on this lovely article that you wrote, a very simple topic, but something that's very important in today's day and age. So Dr. Jim, over to you.
Thanks. It's a pleasure to be here. I very much appreciate the invitation. And of course, we all live in a Zoom world now. So I'm coming to you from Toronto in Ontario, Canada, where I live. And in fact, spent most of my professional career at a hospital called Hospital for Sick Children. And my practice was mostly pediatric foot. I called myself a pediatric foot surgeon. And that was about 75% of the patients that I looked after. I also looked after the Spina Bifida Clinic for 25 years. And of course, many of them suffer from foot problems. So that's where I spent my majority of my career. And I'm happy to talk about club feet. And I'm certainly willing to talk about the struggles of doing research, because I certainly have experienced many of the struggles, no doubt that you also have struggled. So I wanted to start out by saying, why is it we read the surgical literature, the orthopedic surgical literature. Why do you read the orthopedic surgical literature? You know, for some people, it's kind of fun. It's interesting. It's a bit like it's reading the latest news. But I would say the main reason we read journals is to ask the question, is this going to change the way I practice? Is this going to help me looking after children with orthopedic deformity? So when I look at an article, I think of it in two ways. Is this a patient population that's of interest to me, of relevance to me? And if so, are the methods and the results such that there's a lack of bias that would lead me to believe the conclusion's good and it will change my practice. On the other hand, if it's a topic of which I don't have much interest or no clinical experience, I might not even bother to read the article. Once I've crossed that threshold, then I talk about the methods and I try and decide, are the conclusions valid? If they are, then maybe it should change my practice. So I'm going to use that in looking at this article, which is looking at recurrence of clubfoot. And my guess is virtually every pediatric orthopedic surgeon in the world treats some child with club feet. So club feet is a very common topic. Unless you exclusively restrict your practice to spine or tumors, pretty much every pediatric orthopedic surgeon looks after club feet. And if you look after club feet, then some percent of your patients are going to recur. Now we're going to get into a little bit about what does that mean, recurrence? And it varies depending on how you define it between probably 20% and 40%. So this is something that's going to confront virtually every pediatric orthopedic surgeon. And we very much relied on Ignacio Ponseti, who changed the way we treat clubfoot from a largely operative approach to a very minimally operative approach, which we call the Ponseti technique. So his thoughts and experiences have shaped the way we've treated this disorder worldwide, a complete transformation during my career. And most of the child who recurred, he suggested required a tibialis anterior tendon transfer. So you take all or part of the tendon from the inside of the foot and you transfer it to the outside of the foot. Interestingly, there's not a whole lot of work on what is the outcome of that procedure, but there are a couple of studies that suggest it also has a pretty high failure rate. So we at the Hospital for Sick Children and myself thought, well, let's maybe hold off on surgery and let's see if we can repeat the Ponseti casting. If it worked first time, maybe it could work the second time. So that was the premise for doing the study as we started out. So I'm now going to go clubfoot, really important, recurrence, really important. I would suspect most of you would go, I'm probably interested in the results of the study. So my next question, or your next question is this population, does it make sense? Does it relate to how I treat patients? And are the results valid? So what we did is we took a consecutive series of patients, and that's important. So we weren't selective. We took every patient, and we had pretty high volumes. We had about 700 children, and about 20% recurred. Now, this is a really important point. What constitutes recurrence? Because in Ponseti's eyes, this is what he called dynamic supination. So swing through, the foot internally inverts, or it inverts. As long as the foot dorsiflexed more than 10 degrees, we did not call it a recurrence. And in fact, we found most of those kids do fine. So for us, the recurrence was a foot that lacked dorsiflexion and lacked less than 10 degrees. I have never seen a recurrent club foot that did not have a loss of dorsiflexion. So you have to ask yourself, does that match my experience in terms of recurrence? But that was the definition we used. We excluded all of those that were non-idiopathic, many of the children that Harold will tell you about, because they're just much more complicated. So complex club feet, arthrogrypotic syndromic. So what was the control group? And this is the interesting thing, and we'll get to the limitation of this particular study, but we didn't do tib-ant transfer as a primary procedure. Would have been nice, because then we could have compared the two groups, but we didn't have that. So instead, we looked at a group of children who hadn't had recurrence when we started the study. And we said, well, if casting can return the recurrent group and put them back on track with those that haven't recurred, well, that probably means we didn't need to do surgery. So that's the control group we chose. And when we get to the major limitation of the study is the question of, when you see a recurrence, at least as we define it, should you recurrently cast or should you do surgery such as a tib-ant transfer? So what outcomes did we look at? Well, we wanted to have a foot that had more than 10 degrees of dorsiflexion, that was well shaped, and it had not had further surgery. So a pretty exacting definition. But of course, just the shape of the foot doesn't tell you how the child is functioning. So we also used an outcome, what are called PROM, a patient report outcome measure. And the one we used is something called the disease-specific instrument. It's been used a lot in clubfoot, and it's basically a measure of function. So what we did is we called up all the patients, and we got slightly more than half came back, or we were able to see. So we were able to get to look at their foot. We were able to examine. And 6 years, that's a pretty long time. But of course, it varied. Some were only 2 years and some were much longer. And that's always the problem when you're doing what we call a retrospective study, which is we look backwards rather than saying, okay, starting today, we're going to do the study and follow everyone prospectively. So I had someone, a research student, independently assess all these patients. And that's the big problem for orthopedic surgeons, I would say, is you just don't have time to do the kind of studies that needs to be done to do research. And so I was lucky enough to have a medical student come from the Netherlands. And she came, and I think she spent 3 months with us or 6 months with us. And she followed up all these patients, and she wrote the first draft. So we had about a 20% recurrence rate of our 700 kids. And what did we find? Well, some of them, most of them, had 1 cast. 19. 9 had 2 casts. 4 had 3 casts. Now it's getting kind of like a lot. And 2 had 4 casts, and 1 child had 5 different sets of casts. So what were these casts? Well, we put on a below knee walking cast and maximum dorsiflexion. We changed it every 2 weeks. We stretched that muscle. And every time we got a bit more dorsiflexion. And when we got more than 10 degrees, we said stop. So most children had 3 casts, some had 4 casts, and they usually went into a brace afterwards. So that's the casting regimen that we used. So I think it's pretty reasonable to say 5 casts, 5 sets of casts, not 5 casts, 5 sets of casts is way too much. And those were a couple of parents who just refused to have surgery. The foot kept coming back, and they said, well, we want 1 more set of casts, and they were willing to go through it. But that's one of the things in the study we thought probably after you've done 2, maybe 3 sets of casts, there's probably not much value in continuing. So we had a 74% success rate. So those children had more than 10 degrees of dorsiflexion and a well-corrected club foot. Interestingly enough, even in those who weren't recurred, because according to Ponseti, you can usually discharge children from your clinic about 5, 6 years of age. Many of these children we followed up at 10, 11, and 12 years of age. And in fact, we found 16% of them ended up having a foot which lacked, the foot didn't come plantar grade. So we had 84% versus 74%. So we weren't able to get them back in terms of the shape of the foot, back to similarly to that group that didn't have a recurrence. Well, what about the function? And that's in table 2. And if you look at the bottom, the total score between the recurrent group and what we called the control group, the recurrent group had a score of 83 and the control group had a score of 88. Now that wasn't statistically significant, but you might argue 5 points. Again, we didn't quite get them back in terms of their function of the control group. So what did we conclude? We concluded treatment with casting was successful in many patients and may be a reasonable choice for recurrent idiopathic club foot. So that was our conclusion. But what are the limitations? Well, the main limitation is if you really wanted to do this study and get the answer, you would have a group of children with club foot, a certain percent would recur. Some of them, ideally randomized, would have serial casting, and the others, randomly allocated, would have surgery, such as a tib band transfer. And then at the same point, at some future time, 3, 4, 5 years from the point at which they were enrolled, you would determine their outcome. Does the foot look good? Does it function okay? So our lack of that control group, it's a limitation. So I can't tell you that serial casting is the right thing to do for a recurrent club foot, but I can tell you that 74% of them had a foot which is well-shaped, functioned very well, and had more than 10 degrees of dorsiflexion. So that's the main limitation. The second thing is, like any study done retrospectively, even in Ontario, sometimes it's hard to track down people. People move, kids grow up, so it's hard to track. So we had more than 50% of those that we should have been able to follow up, but you always wonder about those that don't return. The last limitation, of course, is this was on average 6 years of follow-up, but we know pretty much everything we do in pediatric orthopedics. What we really want to know is how people are doing in their 20s or 30s, or even, for hip disease in their 50s and 60s. So my conclusion coming out of this paper, I think it contributed to the literature. I would say that for the vast majority of recurrent club feet, provided you accept our definition of recurrence, is you should try serial casting. And I don't know how many times, at least I would say if the parents are okay, 2 different episodes of serial casting looking to get more than 10 degrees of dorsiflexion. And if that fails, you should do a tib band transfer. And to go back to my original point, there is one study done by Park from Korea that said there's a high failure rate after tib band transfer. So it's not as if it is a treatment with really universally good results. So I can't tell you conclusively, but that's what I would get out of my paper. And I know that we continue to treat these children very similarly at the Hospital for Sick Children. So I think I'll stop there. I'm just about at my 15 minutes, and I'm happy to participate in any discussion.
Thanks, Dr. Jim. I think that was an excellent discussion of your paper. I think a couple of questions from the audience. I think the first one that I have is, as you rightly pointed out, how could we be more objective in our definition of recurrence? Because we have always been struggling with this definition. It is so subjective. We say any reappearance of the original cave deformity, but how much? We know that minor imperfections and a little bit of forefoot adduction, a little bit of curved lateral border is all very tenable with a good result. So how objective could you really get in defining recurrence? And is there anything that you have found in your practice after this research to help you define recurrence in more objective terms?
So to re-emphasize this point, I have never seen a recurrence other than, as you said, a little bit of adduction, which is usually dynamic, not static, and dynamic supination, which I think, unless it's a fixed deformity, I don't pay much attention to. So the most objective sign that I have found is a loss of dorsiflexion. So after you treat it with the Ponseti casting, you do the tenotomy. In idiopathic, I'm not talking about arthrogryposis, because Harold's presented some interesting way of treating arthrogrypotic club feet. I'm talking about idiopathic club feet. Usually you get like 30 degrees of dorsiflexion. And then they go into their boots and bars, and you see them at a year, and maybe it's like 20 degrees. And then you see them at 2 years, and maybe it's 15 degrees. And then you see them at 3 years, it's getting like about 10 degrees. And at age 4, suddenly the foot is plantar. So that's the most objective that I have found. And that's the definition we use in our clinic. If we can't dorsiflex beyond neutral, that's when we suggest repeat casting. And we do it up to 7, 8, 9 years of age, usually not much beyond 7 or 8 years of age. But for a parent who doesn't want to have surgery, we'll give it a try, believing that the risks are very minimal of serial casting. So to answer your question, objectively, we can objectively measure dorsiflexion. There's a picture in the paper of how we do it with a goniometer. The older the child, the more accurate the measure. And if the foot doesn't come plantar, we call that a recurrence.
Great. Thank you so much. We also noticed from your paper that in Toronto, especially the sick kids, the clubfoot casting is physiotherapy-led. And while you have shown in the previous paper that that's excellent, because you have shown, I think, that you have got even better results with physiotherapists doing the casting than orthopedic surgeons. But we've also seen in some programs where that happens, that the referral to the orthopedic surgeon for the tenotomy is less than if it's done by an orthopedic surgeon. And I noticed from your paper that the tenotomy rates of the Achilles tendon was about 66% against the usual recommendation of 85 to 90% of children undergoing a tenotomy. I know in India, and I think Matthew's there on board with us, and he will bear me out on this, that we have a very low threshold for doing an Achilles tenotomy, because very rightly, as you've said, most children in the Indian subcontinent want to squat. It's a very important feature of their daily life. And could that be a factor to have led to your early recurrence in your cases? Because you have said that in the recurrent group, squatting was a problem, and they had limited dorsiflexion of around 10 degrees or so. So could that have been a factor, the reduced rate of tenotomies in your paper?
Yeah, that's a really good point. I struggled with tenotomy. So to take you back to the previous paper, also published in JBJS, and in that case, we compared orthopedic surgeons treating clubfoot versus physiotherapy. And before I answer your direct question, our physiotherapy clinic, our physiotherapists, there was one and then there are two who do nothing but club feet. So these are not occasional physiotherapists who wander into the clinic. That's all they do, is they do club feet. And, you know, physiotherapists are expert in musculoskeletal manipulation. This is what they do in their daily life. And so I would train them. The clinic ran concurrently. So it wasn't as if the physiotherapists were off doing club feet and the orthopedic surgeon just said, see you when you're 2. We ran the clinic together. The physiotherapist often brought me in to say, well, you know, let's have a look, see how things are going. I would tell you that physiotherapist became so expert in applying casts and putting them on because she did it. You know, I would normally have 10, 12 club feet every clinic day. So she would be, like you can imagine, all of the casts she got to put on, where I was running up and down the hallway, like doing all sorts of other things. So that's all that she did. And it happened to be a she, and she got very, very good. So our indication for tenotomy was less than 20 degrees of dorsiflexion at the end of casting, Ponseti casting. As you know, that's somewhere between 3 and 5 casts. I don't know whether we should have had a lower threshold. Some clinics have a 90% tenotomy, some have almost 100%, and you know, we have 2/3. We know that clubfoot varies in severity, and I'm always a little worried about cutting a tendon and letting that muscle stretch. Does the muscle catch up? I suspect so, but I don't know. So you're trading off a potential for weakness in plantar flexion, which we know is critical to athletics, jumping sports, even long distance walking. It contributes the majority of energy and gait versus the lack of range. So I accept we maybe have too low a rate. I don't know. So you may be trading off squatting for long distance running skills. I don't know. So I agree completely. That may be an issue in our clinic.
Thank you, Jim. Matthew, do you have any questions for Jim?
Yeah, I apologize. There was no network connection here. I just tried my best. It wouldn't work. I just couldn't get through. Anyway, thank you, Alaric, for chipping in. I agreed with your tenotomy rate question because we have a tenotomy rate key performance indicator for a clinic being over 90%. So we want that in any clinic. If it is doing well, we would expect the tenotomy rates to be as high as 90%. I was looking at the number of new cases. If the total number of cases that you had was 710 in 8 years, which means 90 patients per year or 8 patients per month or 2 patients per week, new cases. So you would have old cases, but for new cases casting, so the number seems to be a little lower than what would keep therapists busy. So I was just wondering, do the number of casts per week have an influence on the outcome of the results? That's number one. Were you doing the therapist-based clinics in the total period? From when did you start the therapist-based clinic?
That's a good question. I don't actually remember. So you're right. So on average, 2 new patients a week, but that's idiopathic club feet. Remember, there were some other club feet as well. We had recurrences. And of course, you have 2 new patients a week. And you have, so you've got 2 new ones, but you've got all the serial ones. So I can't do the math in my head. So, we would at minimum have 6 to 8 children at any one time being casted on a clinic day, and my clinic day was a Wednesday, and sometimes it might be 10 to 12. So it varied a lot. Does the volume affect competency? Well, we know there's a certain minimal threshold for just about anything, whether it's surgeons doing procedures or someone doing casting. I would say that after 6 months, the physiotherapists were better than the surgeons. Whether, I spent some time in Ethiopia at the Cure Hospital, and I suspect you in India are overwhelmed by the number of club feet. So it's very likely you have more experience, more hands-on experience than we do in Toronto. Now, Toronto, Sick Kids is the major children's hospital in Ontario. It's the biggest children's hospital. But, by international standards and some of your standards, it would be a medium to smallish hospital because it serves a population of about 4 or 5 million people. So I think we had sufficient expertise that wasn't an issue, but, your point is well made. The more you do, the better you get at things.
One more question regarding the instrument for evaluation that you've chosen. The DSI of Benjamin Roy it basically has 10 points. And the first 3 points relate to cosmesis and social interaction. 4 and 5 relate to shoes. 6 and 7 relate to pain. And then the walking, 6, 9 and 10 relate to pain. And walking and running are 7 and 8. But it does not include squatting as an ability, which is not an issue probably in a Canadian or a North American population, but it's a major social problem in this part of the world. So would you recommend that, maybe in the DSI sometime down the line, squatting ability could be included as a evaluation point? Would you suggest that, because you yourself have used it as an index for assessing your children? So your DSI that you've used does not use squatting ability, but you've used it. So would you recommend that it is a recommendation for evaluating these kids?
So I think we're one of the few studies in the world that's actually looked at squatting. And I would say that it reflected a very multicultural, Toronto is one of the most multicultural cities in the world, with people from all over the world. London, New York, maybe the only other two which rival Toronto. And I'm quite proud of the fact we looked at the ability to kneel. And you're absolutely, we even have a picture in the paper where we
Yes,
thought.
that's I saw that. I saw you've used it. You've used it. So would you recommend it? I
Yes.
think it seems it's a good point to be looked at.
And I think that's, the point, which is when you talk about function, we all think about running and jumping. Absolutely. But in some cultures and in some families, kneeling is the most important thing.
Yes.
So let's talk about what's important to the population you're looking at, because we came with good DSIs, but you're right. In terms of function in those cultures where kneeling is important, it would not be nearly as good. So I absolutely agree. Whether it's part of the DSI, it should be measured independently.
Yeah, one more point before we close. The recommendation about the follow-up period. So while when the child reaches age 4, we have a cutoff age for 5 years for brace protocol. So while the child reaches age 5, we give them special candies. You're now free from the brace protocol. However, we do not free them from the annual visit till they are skeletally mature. And for girls, it's 12 years. And boys, we keep it around 14, 15. So we tell them, don't stop coming annually. That is your new birthday that you have to remember to come to the clinic. So would you suggest that as the recommendation, as the conclusion? Because that's an important conclusion of your paper, that follow-up should be up to 7 years, not just 5 years.
Yeah, so as you know, many clinics stop the Ponseti boots and bars between 3, sometimes 4. They see them maybe 1, maybe 2 times. If the foot remains good, they say, off you go. You're fine. And you're absolutely right that's one of the things that we recommended. Whether it needs to be just skeletal maturity, I can't answer. But I definitely think it's to like 9 or 10, and maybe it should be 12 or 14. So I agree completely. And our practice somewhat changed based on this. So we may not have seen them every year. We may have seen them every other year. And of course, the other thing about the squatting test, it might be a good screening test. Even if you don't need to squat for your culture, if your child can't squat anymore, that tells because they can't measure dorsiflexion, but they can tell whether their child could squat. And we've begun to think maybe that's something we should be looking at as a screening test. If your child could squat and can't anymore, you should come back to clinic.
Thank you.
Thank you so much, Jim. And thanks, Matthew, also for this lovely discussion. There are a quick couple of questions before I turn it over to Harold from the audience. So, Dr. Jim, if you could quickly answer just these few questions. One from Harold, which says that could it be that club feet with recurrence are in some way inherently different from those that don't have a recurrence?
And the answer is yes, Harold. Club feet is, as you know, it's multifactorial inheritance, meaning there's multiple genes. And certainly when I used to do, extensive club foot surgery, sometimes you would go in and the tissues would separate and, everything would fall into place. Other times it would be a struggle. The joints would be contracted, and it wasn't arthrogryposis. It was just a regular so-called idiopathic club foot. So you are absolutely right. Those that recur, I am certain, whether it's the soft tissues around the joints, whether it's the muscles, whether it's the tendons, but they are clearly, there is a spectrum of deformity. I suspect some feet, you probably minimally need to treat at all because they just respond so well to, even stretching. So the answer is yes.
Thank you.
Good. The other question is, how easy is it to convince parents about recasting? And is there any specific tips in the plastering technique to treat a recurrence?
Well, most of the families come in with a horribly deformed foot, and they've watched this foot unfold with Ponseti casting, and they can't believe how successful it is. So I would say that was not usually a big struggle for us. We sometimes timed it because, of course, unlike you, we have 2 very different seasons. Winter, where everyone has to wear winter boots because it's snow, and summer, where they want to go swimming in swimming pools and the lake. So we did a lot of casting in the spring and the fall. If families refuse, you say, okay, the option then is do nothing, or we could do surgery. It wasn't a big problem because they were so enamored of Ponseti casting. I said, I'm going to do it again. And they're like, great, make the foot look perfect. I don't want to take any more of Harold's time. I want to hear about hip osteotomies.
There's just a last question, which says that before you do a tibialis anterior tendon transfer for a recurrent club foot, how much abduction do you need to achieve by serial casting? And that's from Sri Lanka, Dr. Dimuthu.
Yeah, so often prior to surgery, I would do a few serial casting. I would like to see the lateral board of the foot come just about neutral. But often when I would do, for those that did not respond to casting, I would do a cuboid decancellation, often a hindfoot released ankle, particularly in subtalar. And then I would transfer the tib back over into the cuboid osteotomy. Because you decancellate what Norris Carroll used to call decancellate the cuboid, you basically shorten the lateral column and you achieve a slight abduction of the foot intraoperatively. So it's nice to get it straight laterally, but because you take out the whole insides of the cuboid, you can make the foot, the lateral border straight. In fact, a little bit of abduction.
Great. Thank you so much, Dr. Jim. We really enjoyed listening to your talk. It is really excellent from years of experience that you have dealing with this deformity. And we turn it over now to Harold. Harold, could you share your slides and share some of your experiences in treating arthrogrypotic hip deformities, and allow Binothi to take over the discussion after Harold finishes his presentation. Thank you.
My pleasure. And I want to make sure everybody sees my slides up there.
Yes.
Thank you. And I want to say, first of all, it's a huge honor to be invited to give this talk or to be part of this journal club. And more so because I'm sharing a virtual podium with my former mentor, Dr. Wright. And again, just really enjoy the conversation we just had. I learned a lot there. So I'm going to talk a little bit about my work with arthrogryposis, and particularly what we did for the hips. There's no significant disclosures here. So the thing about arthrogrypotic hips is that they greatly influence the ability of a child to walk. You know, if you have terrible foot deformities, you can walk. If you have terrible knee deformities, you can still walk, but not if you have hip contractures. They just get in the way of walking. So we started saying, well, if we have these kids who have these multi-axial hip contractures, what can we do to help them sit? And also, what can we do to help them walk? And what we start realizing is they actually have a fair amount of good hip motion. It's just in the wrong plane. So we came up with the idea of reorienting the lower limb with the body. So essentially doing a cut in the top of the femur so you can rotate everything so the knee is pointing in the right direction, maximize the flexion extension range, and see how that would go. So we had 65 patients over about a 4-year period with a minimum of 2-year follow-ups. And there's a total of 119 hips that we worked with. And we looked at flexion extension range, frog leg, regular abduction, adduction, as well as internal and external rotation with the hips in extension and with the hips flexed at 90 degrees. And we collected this at the time of surgery. So when they were under anesthesia, we could really get a good measure. At the time of hardware removal, which is a nice time to do it again under anesthesia. And then we looked at the latest follow-up. And so just to go over the techniques, this is, we're going to use this girl as an example. She had a 65-degree hip flexion contracture. When you try to adduct her, she would come to 35 degrees short of neutral. And when you tried to internally rotate her, she'd come to 35 degrees short of neutral. So that's what her hips X-ray look like when she's just lying comfortably. And so I created a bone model that looks like her. And the first thing you do is you put the hip in a kind of its natural position, and then we would lay what we call the pelvis axis wire. So just a wire that went from anterior superior spine to anterior superior spine, putting that on the skin and taping that down so that on fluoroscopy, you had some kind of a reference of where the pelvis was. And then we take a guide wire into the proximal femur at the level that you normally would for doing just your regular varicose rotational osteotomy, but you'd put that guide wire parallel to the pelvis axis wire in all planes. And just insert that in. Now, what that usually means is that the hip was relatively externally rotated. So you would get this funny oblique positioning of your wires. You see in the lower left-hand corner there. That would actually, in a certain sense, help because you would have bicortical purchase. And then we take a cannulated seating chisel, put that over the guide wire, and we would make the seating chisel perpendicular to the floor of the operating room or parallel to the plane of the pelvis access wire, and just insert that into the bone. And again, that would oftentimes be bicortical, and excuse how long that guide wire is sitting there in the soft tissues. And then we make 2 osteotomy cuts. The first one would be about 5 to 8 millimeters below the seating chisel, and the second one would be perpendicular to the shaft. And oftentimes the lesser trochanter was removed as part of this wedge fragment that you're taking out. What we would do is just elevate the iliopsoas off the lesser trochanter, leaving it in continuity with the periosteum, and that would actually then just heal up over time. So here we've done our first cut, then we do our second cut, correct rotation, and use a cannulated blade plate. This is just a typical cannulated blade plate. Not going to talk about vendor here. Has an offset. You would pack that into place, and then we would affix the shaft to the proximal fragment there. Now, oftentimes, if there was a large flexion contracture, there'd be the spike of bone, or if you're correcting a lack of hip flexion, you'd actually be a spike in the back there that you'd have to do. But you take that spike off so that it would not impinge upon the neurovascular structures or on the acetabulum. So just osteotomize that off. So here's a timeline. The girl that we were just talking about, this is what she looked like just before surgery. Here she is right after she's healed up her osteotomies. And you'll see that little bump there. That's the same in both pictures, because essentially we've taken what she looked like before surgery, did the proximal femoral osteotomy, left the ball where it was in the socket preoperatively, and just brought the leg down, reoriented the leg with the proximal femur. And here she is actually at 10 years follow-up or so. And you see that her greater trochanters have kind of migrated back up to the normal position. She's in a fair amount of coxa vara, definitely, but she's up walking. Another child, here he is pre-op, here he is post-op, and there he is up walking. And here he is at 12 years of age. And again, you can see how you get that remodeling that happens, the proximal femur. They'd be in a Petri cast for a total of 6 weeks. At 3 weeks, if the x-ray showed good healing, we'd actually get them standing in the cast. And the cast came off, we put them in knee, ankle, foot orthoses and get them up walking and standing. So this is all our data, but let's just kind of break it down. First of all, the age range that we did was between 13 months and 13 years, but on average was about 4 years of age. We take out the hardware on average 18 months afterwards. The typical arthrogrypotic hip contracture, about 70% of these kids, they had a flexed hip, abducted, and externally rotated. So if we look at those that had a lack of hip extension, they had greater than a 20-degree hip flexion contracture, that was 81 hips. The average preoperative contracture is 52 degrees. Postoperatively, we got them down to 17 degrees, and they maintained that even at follow-up. Those that lacked adduction, they went from 20 degrees short of neutral to nearly 20 degrees past neutral. Same with internal rotation. We improved that from approximately 16 degree short of neutral to 20 degrees past neutral. The total arc of motion, if we looked at the flexion extension total arc of motion, it was 73 degrees preoperatively, and that went to about 85 degrees at follow-up. And I think that was just because now that they're walking, they're actually exercising that hip more, and that would improve the range of motion. Now, the one big fallback was the fact that those kiddos who did not have good hip flexion before we operated, we did not improve that very much. It was statistical, but it was not clinical. So we had 25 hips that did not have 90 degrees of flexion before the procedure. You can see that the average was 63 degrees, but it was as short as kids that would only flex about 25 degrees. And postoperatively, that 63 degrees went up to 74 degrees, but still there were hips that only flexed about 40 degrees, which of course causes a lot of problems with sitting. And that has actually become a big part of my my practice now, is trying to correct those hips. And part of the problem is, here's a CT scan of one of those children, and you see that on the patient's left hip, which is on our right side, the ball is protruding a little bit anteriorly, but on both sides, there's a lot of external rotation of the proximal femur, bringing the greater trochanter to the back of the ilium, and we find a lot of scar tissue back there. So we did other procedures in a lot of these hips. We did anterior hip releases in about half of them, and that was either at the time of the surgery or that would be at follow-up. Posterior hip releases, we did that in those children who we could not get the hip to flex up very much. What a posterior hip release is, essentially releasing everything off the linea aspera so that you get enough soft tissue laxity, hopefully to get the hip to flex up further. And a few adductor tenotomies. And in one child, we actually had to do a greater trochanteric hip resection later on down the line to try to improve that hip flexion. Also a lot of foot and knee procedures that we did. But here's really the most important thing. Preoperatively, only 6 of these patients were ambulating, but at follow-up, we had 36 patients that were ambulating. And you can certainly say, well, it's because you operated on a lot of these children when they were younger. But again, our average age of the operation was at 4 years of age. And at the time of this, of writing the paper, 20 of the patients were still walker dependent. And usually I look at the walker dependency as just being a stage on the journey to walking independently for most of the orthogrypotics. 9 of the patients were non-ambulatory. And in some of these kids, we actually did the procedure really to allow them to sit well versus trying to get them to walk. We did have about 8% complication rate. 4 children had fractures, 3 had surgical site infections. There was one very embarrassing problem where the guide wire got sheared off within the femoral head and actually was crossing into the joint. So I had to open up the joint to pull that out. One child that needed a recurrent osteotomy done 3 years later because she still had significant residual contracture. And one where the hardware pulled out. Now I'll say that in terms of fractures and surgical and site infections, we see a lot less of those. So maybe something of a learning curve with that. But the hardware pull out, we still see that happening once every so many years. So here's that child, the hardware pull out. It's what it looked like initially. And then you can see how the screws kind of came out over time. And some of that might have had to do with how the Petri cast was applied, that there was too much adduction with that. But he actually did well. He healed that up. Here he is. You can see he's got an external fixation pin there because we're straightening out his knees. And in fact, the Petri cast kind of holds the hip in the position we want in anyway. And so when it heals up, it usually does so in a way that we're happy with it. So my treatment algorithm is I treat the foot deformities at infancy. And again, big adherent of clubfoot casting or serial casting. Hip dislocations or the contractures we treat between a year to a year and a half on average, although a lot of the children I see when they're much older than that. And then the knee contractures at about 4 years of age. And with the severe ones, it oftentimes means an external fixator. So here's this young lady that we saw in the beginning. Here she is when she first started taking steps with her KAFOs. And since that time, she graduated to floor reaction AFOs. This one I thought was one of the most interesting cases. This is what the child looked like. Obviously, it was delivered by cesarean section, but this is essentially what her contractures look like. This was her natural position. So here she is after the osteotomy. And what's interesting is that this looks like a greater trochanter, but that's actually part of the femoral shaft over there when we do our cut. But look what happens as she remodels. There's this greater trochanter slowly migrating to the normal position. Here she's upstanding and walking. And here she's at 10 years of age, where clearly her greater trochanters are in the position where they should be. And again, there she is walking and showing off her range of motion. And then this last patient here, this is Daryl. He went through all the same treatment. And here he is walking. Now, you had some questions about challenges for research. One of the problems was that most of the stuff I do kind of as a solo type person here. So when I, I'm going to relinquish sharing here. That I would start collecting data, start writing things up, and then a lot of other things would get in the way, and it'd be another year further down the road. And you're like, oh, got to get new follow-up data, and this would keep on taking longer and longer to get the paper out. But the other thing was that when I was writing this and presenting this, there was a lot of resistance that you could make children with arthrogryposis better. And so I would present this at our Pediatric Orthopedic Society meeting, and I would get a lot of pushback from the crowd about, well, you can't make arthrogryposis kids better. They don't continue to walk as adults, and comments such as that. And in fact, when I submitted this paper, I had never gotten so many pointed questions from the reviewers. My answer was, I think, 14 pages long to the reviewer questions before I finally got this published. So it's nice to see that the world is now turning around more to realizing that kids with arthrogryposis have potential and we can do more for them to get them up and walking. And with that, I'm open for questions.
So much. I think that was absolutely outstanding series and a wonderful paper. Absolutely, Harold. We have learned so much from it. Binoti, I think we'll ask you to lead this discussion. Thank you.
So first of all, congratulations for such an excellent result in a challenging scenario of arthrogrypotic hip. So as against in your series, you had only 10% children who were ambulators before surgery, as against you had almost 90% of them who had achieved the ambulatory potential post-operative. So if I want to ask you, are there any factors which affect the outcome as regards like the age at surgery or the magnitude of deformity, or for that matter, the muscle power, or any other associated contractures like the contractures of knee or spine? Do they have any bearing on the ultimate outcome?
I think the two things that we've gotten to recognize that make the most difference, one is brain power, that there are certain kinds of arthrogryposis where there are cognitive issues and where they're not going to ever have that ability to walk, that a lot of these kids don't even gain the ability to sit. And in those cases, I make it very clear to the parents that the reason for doing the osteotomies is more for comfortable sitting, so they're not in that wide position that can get their knees closer together and sit in a more regular wheelchair. And then the other issue is that you're absolutely right. There are some kids, and I think they have amyoplasia. We haven't been able to do genetic testing on all of them, that they just have an extremely stiff kind of arthrogryposis. So you can put them in the best positions possible in terms of their hips, their knees, their feet, but things keep on stiffening up and they don't maintain the ability to walk, or they may have never really gotten the ability to walk. They can be very smart children, but everything else is so stiff. And these are the ones that I've started to realize now they end up in motorized wheelchairs as teenagers, and that's what they're most comfortable in. And oftentimes it's the motorized wheelchairs that they have to direct using mouth controls or head controls, because they just don't have the ability to make their arms move enough to be able to even use a joystick. I think that the hip procedure part still makes sense for them because you're still putting their hips in a good position for sitting and for other activities. It gets more challenging to talk about, should we straighten out knees or those kinds of things for these children. I do come back a little bit to how we used to look at myelomeningocele, that we would know that a lot of these children with myelomeningocele would not be walkers, but we would still expend a lot of energy in trying to put them in a good position for standing, because we knew that that upright position was good for their development, even if we knew that they would not be walkers as adults.
Yeah, so that brings to, I think Professor Jim Wright has a question that how do you trade off extension for walking versus flexion for sitting? Yeah, so I think you've partly answered that, but you can throw more light on that.
That's a really good question. And I think at this point in time, the way that my practice has kind of worked out is that, yeah, we put more emphasis on the walking early on and then try to do something about the sitting later. And in the past, it would be, well, I'm not going to worry. I've gone through a long journey with this. I would try to do releases of these children when they were kind of in middle childhood. But then what you'd find is that the ones who have extension contractures tend to have that because they've got really strong gluteus muscles. So you could release them, you could get a great result in the operating room, but then post-operatively, they would fight like crazy and you could not get them to flex up very well with physical therapy. And so they would lose range relatively quickly. Within a year, you're just about back to where you started. So then I would hold off and wait until that they were, say, 10 years of age, thinking that they could then participate better with their physical therapy. Now you've got a lot of structural issues with the hip itself. And that's when we started getting our CT scans, we'd see those structural issues where the femoral head is essentially rotated anteriorly and protruding out in the front, and that's what's blocking them. so I'm still trying to figure out what the right approach is for these children. It may be that at an earlier age or at the time that we do the reorientational osteotomy, that we spend extra time on making sure that the proximal femur is rotated appropriately within the acetabulum, and that we are able to achieve a good amount of flexion early on, so that when they're in their Petri cast, we can cinch them down to the wheelchair, pull them all the way back to maintain that hip flexion, and then just be right on top of it from the very start.
And in the very severe deformities which you showed in the model, like very severe, say 70, 90 degrees flexion, do you anticipate any time any neurovascular compromise or any tips on preventing when you do an acute correction, any stretch on the femoral nerve or anything?
I haven't had any problem with doing the reorientational osteotomies in terms of neuropraxias. Some of that may be that I'm not quite sure why that is. I mean, there's a little bit of shortening that goes on when we do the osteotomy. In terms of the femoral nerve, I was going to say that they usually don't have working quadriceps, so maybe you don't know that you've done anything to the femoral nerve, but they don't complain of any sensory issues by and large. I've had more problems when I'm trying to get the hips to flex, that I can get some stretching of the sciatic nerve. Again, not with the reorientational osteotomies, but more in these newer procedures I've been doing. So I can't explain why that is. I'm not having problems with the bad flexion contractions, getting them to extend, but I haven't seen that.
And Dr. Rujuta Mehta has a question that can this be done for bilateral hip dysplasias in AMCs, where usually like bilateral hip dislocations we tend to neglect, but and leave them alone. But do you advocate this procedure for them as well?
Oh, now you're getting into a whole other pocket of good stuff. So I'm very pro putting the hips back in the arthrogrypotic children, except for those that I think do not have sufficient brain power. And in fact, in those cases, I will tell parents, I'm just going to keep watching your child. And if your child then starts showing some ability and some interest in walking, I will put the hips up, put the hips back into socket up until about 5 years of age. The oldest I've done was a little over 5. But I've been very proactive about putting the hips back in and hope to get a paper out in time. Same issue. It's been written 5 years ago, and every time it's like, oh, got to re-up the data. But yes, I think that putting the hips back in is an important thing to do for these children. The concerns in the past were that the hips would become stiff or become painful. And what we found, and particularly when we were looking at either the preoperative motion compared to the postoperative motion, or even better, those that had unilateral hip dislocations, we would find very little change in total arc of motion when you put the hip back in. And haven't had too much trouble in terms of redislocation, except for the children that have some of these very severe brain abnormality type syndromes.
Dr. Sandeep Patwardhan has a question that do you do soft tissue release as a first step prior to doing the osteotomy in order to reduce the magnitude of deformity?
Right. So in my paper, I talk about something that we call the percutaneous anterior hip release. And this is something we'll do as a solo procedure if the child just has a hip flexion contracture without much of an abduction or external rotational contracture. And then what you actually do is you can feel the conjoined tendon coming down from the anterior superior iliac spine, the tensor fasciae lata and the sartorius, and you can just through a small incision, you can nick that. And sometimes you have to go a little further down to do that. But that is oftentimes the first thing that I will do in these procedures so that I have less total correction of the flexion contraction that I have to do through the osteotomy.
Any specific post-operative rehabilitation protocol or physiotherapy protocol? Because I'm sure the muscles need to be trained a lot in order to get the osteotomy result.
Oh, absolutely. So we start off with, at 3 weeks, we get an x-ray in the cast. And if that shows that my osteotomies are starting to heal well, then I will have the parents start standing the child in the cast. And even if they have really bad knee flexion contractures, they can still pretty well do some guided standing in the cast. And then when the cast comes off and we put them in their knee, ankle, foot orthoses, then we get a lot of physical therapy going. So oftentimes at that point, walking with walkers or with crutches, and we just keep on pushing it that way. But yeah, in the best of all worlds, all my patients would get physical therapy at least twice a week, and every day they'd be doing their exercises with their family at home.
And anytime do you do a multi-level surgery like we do in cerebral palsy, like you tackle the knee contracture also at the same sitting, or you always stage them?
So when I look at treatment for knee contractures, for me, there's two big pots. It's the mild to moderate contracture, where I can do a femoral anterior distal hemiphysiodesis, putting growth retaining plates in the front of the distal femur, or the more significant ones that need an external fixator. So if it's just the femoral anterior distal hemiphysiodesis plates, I can do that at the same time as my reorientational osteotomy. The only problem is that you need a child that's big enough, and that usually means a child of about 4 years of age or so. So if I'm doing the reorientational osteotomy in a very young child, there's just not enough real estate to be able to put those plates in place, so I don't do that. But in the run up to surgery, we do a lot of clubfoot casting, so that in the operating room we can do the Achilles tenotomies. I also have some very talented colleagues who do the upper extremity work for my children with arthrogryposis, and it's not unusual that we'll share the operating room, that they're doing something on an arm while I'm doing something on the legs, and we leave one arm over for anesthesia, and they get very nervous with us, but that usually works out pretty well.
Dr. Alaric, do you have any further questions or anything more you want to discuss?
Well, I think maybe just one question, Harold. Did you feel that when you did your redirectional osteotomy of the hip, if you shorten the bone a little bit more, would you have some improvement in the knee flexion deformity as well? So you may not need to do something further if they had milder degrees of knee flexion deformity?
So that's a good question. And that's one that my partner, Sarah Nassov, was interested in as well. And she's looked at that a little bit. She hasn't gotten back to me in a while to tell me if she thought that made a big difference. But that might be the kind of thing that we do realize in time, is that you can do more things. Maybe not so much with the knee flexion contractures, but it might be a great thing to be able to do for the knee extension contractures, where you can do your Judaic quadriceps plasty, your femoral shortening, and your reorientational osteotomy all at the same time. And that's not a bad thing to do for a child who's about 2 years of age.
Great. So I think I've had some really excellent discussion on both the papers. And we have reached the right amount of time that we have devoted to this topic. So I'll call upon Dhiren as President of POSI to give us a short vote of thanks.
So before Dhiren joins in, I just want to compliment both the gentlemen on the fantastic quality of the papers and the discussion and the talks today. And in fact, I think what Jim has really taught us is that it's really important to prioritize function. And Harold's just given me a great idea to do some reorientation osteotomies for the upper limb. So thank you for that. And over to Dhiren, and may I request everyone to stay in for a screenshot? And Al, if you could do that.
Yes, so like I request everyone to switch on your video so that we can have a...
Okay, great. Couple of people more, I think. All right, smile everyone. Thank you so much. Dhiren, over to you.
Yeah, thank you very much. Thank you, Jim and Harold, for a wonderful exposition about your research. And Harold, your one comment about like 14-page answer to the reviewer is really interesting, and that will always give a perseverance, like when we are frustrated with the so many questions. So we will remember that. So thank you once again for joining with this program, Wadia Children's Hospital and POSI. And I'm sure that we are going to have more sessions with both of you. So thank you, and thank you once again to our colleagues for taking part in this session.